Okay, I think you have listened to a few of lectures regarding the pathophysiology and the clinical manifestations and everything. So here, not about 15 to 30 minutes, I'm going to talk about pediatric TB. So actually, it is very difficult to cover the entire pediatric TB within like half an hour. But if you are really interested, you have few free guidelines to go through if you want to learn pediatric TB in details. The first one is National Guideline in Sri Lanka, which was published in 2018, and then WHO Guideline Pediatric Chapter, which was published in 2022, and the TB Elimination Program Indian Guideline. All are equally good. And apart from that, we have our National Latent Tuberculosis Guideline, as well as National TB Tuberculosis Manual, as well as Diagnostic Algorithm for the Pediatric Tuberculosis, which was published in 2020. It is very comprehensive and it is very easy to follow. And today the main topics I'm going to discuss pulmonary tuberculosis in children, and I will specifically tell you how it is different from adult and what is new. And very small, very brief talks about perinatal tuberculosis, absent BCG scar, adverse BCG reaction, latent tuberculosis, and if time permits, extrapulmonary TB in pediatric. So, as you all know, pulmonary TB is bacteriologically confirmed or clinically diagnosed case of tuberculosis involving lung parenchyma or tracheobronchial tree. So, when it coexists, when extrapulmonary TB coexists with pulmonary parenchymal disease, usually we classify this as a pulmonary TB. So, miliary TB is also classified as pulmonary TB because it has a pulmonary component. So, diagnosis of pediatric TB is challenging. That's why the low case detection rate is major problem worldwide. Less than 40% of the estimated cases were notified annually, and which is worse in less than 5-year group. And unfortunately, the TB-related mortality is also more in that age group. And the reasons for this low detection is mainly disease-related problems, as well as the other problems. The disease-related problem is actually the paucibacillary nature of the TB in children. And apart from that, most of the time they are unable to produce a good quality sputum. And sensitive point-of-care diagnostic tests are also not readily available in countries like Sri Lanka. So we cannot we cannot go through the state-of-art algorithm follow that in order to diagnose. And misdiagnosis is also very common because most of the symptoms of the pediatric TB usually overlaps with the other pediatric diseases. And primary healthcare sector is having very low awareness about the pediatric TB. So as in adult TB, in order to diagnose, what we should do is going through a detailed history, clinical examination and investigations. What I want to point out here is investigations. We do not need to do whole lot of investigations, and the diagnosis of pediatric TB is not rely on 3 AFBs nowadays like in good old days. The most important investigation are radiological investigations, chest X-ray, and the bacteriologically confirmation by WHO recommended rapid diagnostic test. I think you can read this, no? So this is the 2020 Sri Lankan National Diagnostic Algorithm for Pediatric TB. So according to that, if you find a child with signs and symptoms suggestive of tuberculosis, or if a child is having a high risk factors for developing tuberculosis disease, then we should follow this algorithm. So what are these signs and symptoms of pediatric TB? Mainly, there are like a lot of signs and symptoms are there. Main signs and symptoms like cough for more than 2 weeks. So it is very common symptom in pediatric. Cough more than 2 weeks is a very common symptom. And also weight loss and poor weight gain, you know how common they are, as well as the if you are treating some child with a pneumonia with antibiotic but it is not responding, it can be TB. And also if you are treating a child for asthma but if child is not responding to the inhalers that meet appropriate treatment, that also can be TB. And if child is having a fever more than 2 weeks, as well as poor feeding and anorexia. So when they get exposed, who are having high risk to develop TB disease, active TB. So the children who were exposed to TB non-patient to within like 2 years period, as is having a, that means a close contact within last 2 years. And apart from that, if the child is having HIV, or if the child's parents are having HIV, they have high risk to develop TB disease. And if they are having severe acute malnutrition or immunocompromise, as well as children less than 5 years are having increased risk to develop TB disease when they exposed to TB. And when we go through the guideline, first of all, if they are having signs and symptoms, and if they have risk factors, we should see whether this child is having pulmonary TB or extrapulmonary TB. Extrapulmonary TB usually comes for the, like, not for the pulmonologist. It usually detected by the other physicians, like sometimes surgeons, sometimes neurologists, and dermatologists. It depends on the specialty or organ involved. If you're suspecting pulmonary TB, first thing we should do is do a chest X-ray, good quality chest X-ray, and we should take sputum for gene expert or WHO recommended rapid diagnostic test. If the sample is adequate, we can send for the TB culture. So if the child can produce sputum, so we can directly take it and do it in the chest clinic. And if a child can't produce sputum, child should be directed to the pediatric hospital. From there, they can, that means we can collect alternative samples like nasopharyngeal aspirate after physiotherapy, or we can do induced sputum, or we can take early morning gastric sample, or sometimes bronchoscopy sample. So if the gene expert is positive, despite of X-ray findings, we label them as TB and start treatment. If gene expert negative but still X-ray features are suggestive of TB, then child should be directed to a chest physician or pediatric chest physician. So we will decide whether the child is having clinically diagnosed TB, that is not bacteriologically confirmed but clinically diagnosed TB. If both are negative, still the symptoms are persisting. If you still think this child is having TB, again send the patient to us, then we can figure it out. And if the child is not having symptoms and means symptoms are improving, you can exclude TB and treat for the other possible pathologies. So as a important investigation, chest X-ray, what are the important things regarding chest X-ray? So majority of the children, I don't know about adults, but the majority of the children with pulmonary TB have chest X-ray changes, but normal chest X-ray cannot exclude pulmonary TB. However, these X-ray changes usually mimic a lot of other diseases, so it has a limited role to confirm the diagnosis of TB. However, there are few X-ray features which are specific, more suggestive. If these X-ray features are there, the TB is more suggestive than the other diseases. They are including high-low mediastinal adenopathy with persistent lung opacities or some sort of a segmental or subsegmental collapse. This is due to the high-low adenopathy. And apart from that, miliary pattern, obviously it is mostly TB. And if they are having, especially the adolescents, if they have the chronic fibrocavitatory shadows, it is also more likely TB. And apart from that, if the child is having lung opacities which is not improving with IV antibiotics, that means a certain reasonable course of antibiotic, then you should investigate for TB. And if the child is having pleural effusion or pericardial effusion or dense alveolar opacities, and if children are not acutely ill, if this is the empyema, they should be acutely ill. If it is the pericardial effusion is due to some sort of a bacterial infection, so they should be acutely ill. But in TB, usually they have massive effusions or pericardial effusions, but they are not sick. In these sort of instance also, we should think about TB. Regarding the bacteriological confirmations, we usually do not do acid-fast bacilli now the routing staining. Instead of that, we should go for the WHO recommended rapid diagnostic tests. According to the WHO, now the microscopy should replace with these investigations because due to the paucibacillary nature, microscopy is usually not positive. And also, these rapid diagnostic tests can be done in the respiratory as well as other samples. So the main, I think you will get a lecture, or you already may have a lecture regarding these WHO rapid diagnostic tests. Usually, what you are practicing in Sri Lanka is expert. That means gene expert and expert ultra. So mostly the most challenging part in interpreting these results, when expert ultra results comes as Mycobacterium tuberculosis detected trace. So it is a headache for adult chest physician, because most of the time this can be due to the contamination and that all. But in a pediatric practice, the recommendation is, if it comes as trace, we have to take it as positive because of the paucibacillary nature. So if the report comes as trace, still we take it as positive and start treatment for TB. And also new advances, gene expert can be done in a lot of samples as mentioned here. And expert also can be done in a lot of samples. So it is very useful to detect pulmonary TB as well as extrapulmonary TB. And most recent WHO guidelines, they introduce sampling from gene expert and expert ultra from the stool samples, because children usually swallow their sputum overnight and in the early morning. That's why we take early morning gastric aspirate. So instead of that, we can do the gene expert and expert ultra in stool samples, and it can detect genome, TB genome, and it is practiced in other countries, not yet in Sri Lanka. So the stool gene expert and expert ultra is almost equally sensitive and specific like other samples. And apart from that, it is non-invasive, and the caregiver acceptability is very high for the stool samples. So when we manage pulmonary TB, the treatment outcomes are generally good in children, and children generally tolerate anti-TB drugs better than adults. And what I have to specify here is, we usually do not give any trial of treatment for the pediatrics in order to diagnose and stop halfway. If you initiate a treatment, you should continue the treatment and finish it, unless like alternative sound diagnosis appear, like if we think that some lymph node as a TB, and if we start treatment. But if it comes as a malignancy, then we can stop anti-TB treatment if it is a clinically diagnosed TB, not bacteriologically confirmed, right? So aim of TB is is cure the patient. The aims of treatment of TB in pediatric, the first aim is to cure the patient, then to prevent death from tuberculosis or late complications, and to prevent relapses of TB and risk transmission, as well as to prevent emergence of the drug resistance with minimal drug toxicity. So regarding the anti-TB treatment, specifically what I have to mention here, we should treat according to the weight. Sometimes during the course, you may have to change the drug several times depending on their weight. And as in the adults, it usually divided into intensive phase and the continuation phase. So you know these things. And the first line treatment, again, we usually divide into new cases or previously treated cases. As I don't have much time, I will skip these things. And another important thing I have to introduce, WHO has recently introduced a shorter treatment regime. That means 4-month treatment regime, and it is validated for pediatric also. So we can use a shorter treatment regime, which will introduce into the pediatric guidelines within next few years inside Sri Lanka also. So if it is it is non-severe TB, then we can use the 4-month regime. The non-severe TB means peripheral lymph node TB or intrathoracic lymph node TB without airway obstruction, or uncomplicated TB pleural effusion, or paucibacillary non-cavitatory disease confined to the one lobe of the lung without miliary pattern. So it says the same. And regarding the ethambutol, So it is another controversial point. So many years we did not use ethambutol in the children below 5 years. The concern was like irreversible visual loss due to the optic neuritis, but according to the latest studies, the risk of phototoxicity is very minimal, negligible in the dose we usually giving for the TB. So it is preferred to use ethambutol in children, specifically if they have HIV, or if they live in countries with high HIV prevalence, or if they live in countries with high INH resistant prevalence. And drug adverse effects also the same, drug induced liver injury is the main adverse effect in pediatric. And if it is there, the first thing we should do is to stop ATT and wait until the child recovers. And also at the same time, we should investigate for the other causes of the liver injuries in children, because it is very common. Other causes are very common genetic causes, and reintroduction of the drugs can be done after normalization of the liver function. But if the disease is severe and if disease warrant to continue in TB treatment, so we should go for the bridging therapy, usually with less hepatotoxic drugs like ethambutol, streptomycin, and ofloxacin. That is should be individualized by a chest physician. And when during the follow-up, usually during the 2 weeks interval between the intensive phase and monthly interval during the continuation phase, during that we should assess clinical signs, treatment adherence, and evidence of adverse effects, as well as we should measure the weight and adjust the drug according to the weight. Okay. Then few things regarding the perinatal TB. Infant can get TB transplacentally, or by ingestion or aspiration of the infected amniotic fluid, or through the airborne route after delivery through the close contact. So symptoms are commonly present after second week of life, and these symptoms, you can see these symptoms are very common for the premature infant with a lot of other diseases. So symptoms are non-specific. And the investigations are radiological. The most important investigation, if it is antenatally acquired, ultrasound scan abdomen to see the periportal lymphadenopathy, because that is the port of entry. And postnatal, if it is through the airborne, usually the chest X-ray changes usually appears after the 2 weeks of life. And apart from that, we can take tracheal aspirate, gastric aspirate, urine, CSF, and tissue samples, as well as the histological samples, depending on the clinical picture. During the management, we should not separate the child from the mother if the mother is acutely ill, unless the mother is acutely ill. And we should minimize sharing common breathing space as much as possible. All the anti-TB treatments are compatible with pregnancy as well as breastfeeding. We should not treat, we should not panic. And the sputum positive recently diagnosed mother should wear a face mask during breastfeeding. And breastfeeding should be done in an adequately ventilated room. So there's an algorithm in our guideline to how to treat perinatal TB. First of all, if the mother is diagnosed, we should start ATT, and mother should be investigate for the active TB at the time of delivery, and by a sputum smear. If the sputum smear positive, and if the child is having congenital TB, we should treat. And if the child is having signs or symptoms of congenital TB, if the mother is sputum negative, still we have to treat. And if the mother is sputum positive, and if the child is not having congenital TB symptoms and signs, then we should start INH prophylaxis and continue it for 3 months, and reassess the child after 3 months. And we have to reassess clinically as well as with the Mantoux test. If clinically child is having features suggestive of tuberculosis, we have to treat. And if the child is not having symptoms of tuberculosis, we can do the Mantoux test. And if the Mantoux is positive, that means more than 5 millimeters, then we have to continue INH prophylaxis for total 6 months, and we should avoid giving BCG. And if the MAN2 is negative, we can stop INH prophylaxis and start, we can give the BCG vaccine. In the absence of BCG scar, the first thing you should do is you should check the CHDR. There's a special column for the BCG scar. Some healthcare worker, primary healthcare worker should note it and put a tick if the scar is there. If that tick is there and if the history is suggestive of some sort of a local reaction, we do not need to give revaccination. And if we decided to give revaccination, we can wait until 6 months of initial dose to, and we should give time to reaction to occur. And if the child is less than 5 years, we can revaccinate without MAN2's test. And if the child is below 1 year, we can give the 0.05 milliliters. And if child is more than 1 year, we can give 0.1 ml, then double the dose of the BCG vaccines. And BCG is not routinely recommended after 5 years of age. And if the scar is absent even after second vaccination, means revaccination, we don't need to give revaccination. But according to the WHO recommendation, nowadays they say no need to revaccinate if even the BCG scar is absent if the BCG was given at birth. So our local guideline also will change with time. And regarding some slides regarding the adverse BCG reaction, usually it comes as a non-healing ulcer or abscess formation at the site of the BCG, or enlarged regional lymphadenopathy. This is the most common thing, that is called BCG adenitis, or disseminated infection with Mycobacterium bovis, that is disseminated BCGosis. So local complications usually heal without any sort of intervention. We should let them to heal. And if the BCG adenitis is non-suppurative, we have to wait until it settles. And if it is gradually increasing in size lymph node, we can surgically excise it. If the suppurative lymph node is there are two schools of thoughts. According to our guidelines, what we should do is we should do the excision biopsy first, and excision biopsy. But according to some other guidelines, they say we can do the needle aspiration twice, and if it improves with needle aspiration, no need of excision biopsy. But never we should do the excision INDs, because IND can cause non-draining like fistulas. And if the suppurative node is there and if get ruptured during surgery or spontaneously, we may need to treat with anti-TB treatment. For that anti-TB treatment also, we have two schools of thought. Some recommend, and also in our guidelines, we say we should give INH prophylaxis for 3 to 6 months. But WHO and some other guidelines, they recommend give full ATT treatment. When we give full ATT treatment, we should not give the pyrazinamide for these kids, because pyrazinamide is inherently resistant. Bovis is inherently resistant to the pyrazinamide. So we should give a 3-drug regime in these instances, as well as when you are treating disseminated BCGosis. So regarding the latent TB, according to the latent TB guideline in Sri Lanka, we should do the contact screening of all the close contacts in all sort of TB patients. That is with a checklist and the chest X-ray. But regarding the INH prophylaxis, if the child is less than 5 years, we should give INH prophylaxis for every child if they have a contact with bacteriologically confirmed pulmonary TB. And if the child is above 5 years, we should give INH prophylaxis if they have evidence of latent TB. That means if the MAN2 is more than 10. And we should follow up them at least 2 years in 6-month interval. So few regarding the extrapulmonary TB. So that is either bacteriologically confirmed or clinically diagnosed TB involving the organs other than the lung parenchyma or tracheobronchial tree. Whole lot of list we can add here. And the diagnosis is very challenging, even more than the diagnosing the pulmonary TB, because it is symptoms are non-specific and the investigations are invasive, because we need to do some sort of invasive investigations in order to diagnose this. And whenever extrapulmonary TB is there, we should exclude the pulmonary TB, because it can coexist with pulmonary TB. Then we have to treat as pulmonary TB. So investigations are including either needle aspiration or tissue biopsies mainly. Here what I have to mention is most of the time these extrapulmonary TB was referred to us by pathologists, not by the clinicians, because usually, as an example, most of the time our surgical team, when there is a lymph node, our surgical team excise it and put the whole lymph node into the formal saline and send it to the histology. And the histology report comes as granulomas with certain cells, and they ask us to exclude they ask them to exclude the TB, and they send us the patient with the biopsy report. And at that time, you don't have any other thing. So if you are in some unit, if you are investigating these kits, that means for the pleural effusion, pericardial effusion, ascites, or whatever, so you should send a sample for bacteriological confirmation. And if you are taking a biopsy sample, please put one sample into a normal saline, then we can proceed with the investigations. Right. Okay. These are in addition. Right. Thank you very much.